Tare is the short form of transarterial radioembolization. Transarterial radioembolization is a technique by which we inject a radioisotope directly into a liver tumor by cannulating the hepatic artery and then delivering the radioisotope directly into the tumor. Now, these radioisotopes may be alpha emitting radioisotopes or beta emitting radioisotopes. The most common kind of radioisotopes which are used in this kind of technique is yttrium, which is Y90, which is a beta emitting radioisotope. Now, what we do is that we cannulate the hepatic artery by first the interventional radiologist will puncture the femoral artery and then put the catheter right up to the hepatic artery, cannulate the hepatic artery, cannulate the specific artery which is supplying a tumor, and then deliver the radioisotope directly through that feeding artery. And that is the reason why this is often also called as SIRT, or selective intra-arterial radiotherapy. Now, the advantage of Tare over other procedures like TACE is that Tare can be done even where a person has portal vein thrombosis, which often becomes a contraindication for doing other techniques like a TACE. The second major advantage of Tare is that the post-embolization syndrome, which means that the decompensation or the worsening of the liver function, which often happens after a person undergoes a TACE or a transarterial chemoembolization, does not happen with Tare or transarterial radioembolization. What are the patients who can actually benefit from a Tare? Patients of hepatocellular carcinoma, some patients of metastasis to the liver, especially from kind of tumors which arise from the colon. So patients with colonic cancers who have metastasis to the liver which are not operable, right, which cannot be removed. In such situations, using Tare or SIRT along with the chemotherapy can often augment the effect of chemotherapy on the tumor, especially in the liver, and can increase the overall survival of the patient, as well as give a period where the patient does not need to take chemotherapy. And this is especially true in patients with colorectal cancers. For hepatocellular carcinomas, where a person has a HCC which is not resectable, Tare can actually not just be used as a bridging procedure to a transplant, but can also be used as a definitive procedure, and in some patients who have portal vein thrombosis can be actually combined with external radiotherapy for the portal venous thrombosis, or can be combined with certain immunotherapy drugs to give a synergistic effect on the patients. And often patients with very large tumors which are not amenable to any kind of other procedure come for Tare, and they have a good progression-free survival post-Tare. Tare can also be repeated after a certain period, and it can overall help in the treatment of these patients of unresectable hepatocellular carcinomas.